Hello and welcome. Today we're going to be talking about the National Standards of Healthcare Cleanliness, an introduction to the standards and some guidance on the implementation process for primary care and care home settings. The aim of the presentation is to provide guidance on the application of the requirements of the 2021 National Standards of Healthcare Cleanliness document. Within this session, we will be looking at the use of functional risk categorization, establishing audit frequencies, assessment of elements, performance parameters and frequencies, determining cleaning responsibilities, administering star ratings, participation in the Commitment to Cleanliness Charter, presenting required documentation and implementing efficacy checks. The National Standards document replaces the 2007 Specifications for Cleanliness document with an aim to standardise cleanliness nationally. A visible cleaning schedule with frequencies and responsibilities is already an established expectation that should be part of local infection prevention and control policies and procedures. So all providers need to do is simply adapt what they already have. The main change in the document is that adherence to the standards is mandatory and will be based on a standardised system of auditing and monitoring. The national standards apply to all CQC registered healthcare settings, and the documents will support service level agreements for local cleaning procedures and will be a benchmark against which to compare services. The standards will establish optimum levels of resources needed to deliver safe cleaning and will be part of an ongoing performance and management process. The national standards give a framework for auditing and monitoring and tools for improving service user satisfaction. The standards are underpinned by Regulation 15 of the Health and Social Care Act that requires premises to be clean, secure, suitable and used properly, and that providers maintain standards of hygiene appropriate to the purposes for which they are being used. Regulation 15 of the Health and Social Care Act is something that the CQC will assess providers on during their inspections. The first step that providers will need to take in order to align their already established cleaning processes to the new standards will begin with a review of each area. So because different areas are used for different activities, they have different functions and different risks. And the different functions and risks will then impact on the cleaning methods, frequency and methods of monitoring. So for example, a storage room will not require the same level of cleaning and auditing as a treatment room or even a bedroom or a toilet. There are 6 functional risk categories set out within the National Standards documents, and audit target scores are directly related to the functional risk category. There is an additional functional risk category outlined in the National Standards document, which is called a functional risk blended approach. And this allows flexibility for providers to maximize resources, but it does so with complexity, as a functional blended approach will require an electronic audit system to calculate audit target scores. So if a blended approach is adopted, it must be based on activity of an area, not the type of room. So when providers are taking the first step into ensuring their current cleaning processes align with the new standards, and they are assessing functional risk categories of each area, they need to ask the following questions. What activity takes place in an area or room? For example, is it used for taking blood or is it used for eating? And then who uses a room? Is it service users, staff or both? Is the current cleaning schedule and all the current cleaning processes already aligning with the National Standards document and local guidance policies and standards? And if not, what changes need to be made? And importantly, is cleaning regularly audited and recorded? And if not, what changes need to be made to align with the new standards? This table outlines the 6 functional risk categories and the additional functional risk blended approach. It gives audit minimal target scores, audit frequencies, and also examples of areas that would be determined in those functional risk categories. So for example, a minor operations room or an immunocompromised unit would be a functional risk 1 area. It would be expected to be audited weekly with a minimal target score of 98%. Example of a functional risk 2 category would be rooms where an invasive procedure takes place, for example, wound dressings, phlebotomy or injections. it would be expected to audit monthly with a minimal score of 95%. Example of a functional risk 3 area would be a mental health area or a learning disability setting. It would be expected to be audited bi-monthly with a minimal score of 90%. Examples of functional risk 4 area would be a consultation room where invasive procedures don't take place, an entrance, a corridor, a waiting area, or pharmacy. It would be expected to be audited quarterly with a minimal score of 85%. An example of a functional risk area 5 would be reception, and with the expectation of being audited 6 monthly with a minimal score of 80%. An example of functional risk area 6 would be an admin office, medical records, or a store cupboard, expected to be audited annually with a minimal score of 75%. Audit target scores for functional risk blended areas are combined for rooms within a functional area, and the audit frequency is determined locally. For further information on blended approaches, please see section 5.6 within the National Standards of Healthcare Cleanliness document. The following slides are some examples of some functional risk categories. This slide is an example of a functional risk 1 category, an immunocompromised unit. This slide is an example of a functional risk 2 category, a treatment room. An example of a functional risk 3 category, a glum clinic. An example of a functional risk 4 category, an entrance to a premises. An example of a functional risk 5 category, a reception area. And an example of a functional risk 6 category, an administrative office. There are recording requirements for functional risk categorization, and they are that providers should have a documented rationale for how the functional risk category has been established for each functional area, room, or group of rooms if using a blended approach. And also a documented review of the functional risk category at least annually, and that's just to ensure that the rationale and risk are still appropriate. For example, if the use of the room has changed. It shouldn't take long at all to determine the functional risk categorization of all areas within your setting. And it's reassuring to note that this will take the most time when aligning your current processes to the national standards. The next step of the implementation process will be looking at elements, performance parameters, and frequencies. So once the functional risk categories have been established, a cleaning specification with more detailed information on how cleaning will be carried out will be produced. And this will include cleaning elements, which basically means a list of individual items or categories of items that require cleaning. So for example, a patient couch. Performance parameters, so that would be the expected standard of cleaning of each element, so each item after it has been cleaned. And cleaning frequencies, so how often each element should be cleaned, and that will be broken down by what functional risk category area the item is within. So in the same way that functional areas need to be categorized according to risk, the frequency of which individual items need to be cleaned will depend on the risk category they fall in. So for example, a toilet in a communal area will need to be cleaned more often than one in a low traffic administrative area. Helpfully, Appendix 2 within the National Standards document is an example cleaning specification template that can be adapted for local use, and this has a non-exhaustive list of 50 cleaning items found in most health and care settings. So organisations can add or delete items to the application. The template also details the performance parameter, so that means the expected standard of cleanliness of each element after cleaning. The template is a guide only, but if adapting it for local use, cleaning frequencies should not be reduced below the levels suggested, as these are based on what are regarded to be safe standards for meeting the performance parameters and achieving the cleaning audit target scores. Organisations should base their decisions on frequency, on infection control risks, but also consider patient and public confidence in aesthetics. So, for example, the floor in a public corridor will not generally be considered a high infection control risk, but its cleanliness will significantly impact on service user confidence. So this is an excerpt from the cleaning specification template, which is Appendix 2 within the National Standards document. So if we look on the first line here, we have number 32, and the item that it is given the parameters for are low-level surfaces, which are including low-level pipes and low-level trunking. So the standards expect the performance parameter to be that all surfaces should be visibly clean with no blood or bodily fluids, substances, dust, dirt, debris, adhesive tape or spillages. And it also outlines how often the low-level surfaces should be cleaned according to the functional risk area. So for functional risk 1 areas, low-level surfaces will be expected to be cleaned fully daily. Weekly in functional risk 2 areas, weekly in functional risk 3 areas, fortnightly in functional risk 4 areas, monthly in functional risk 5, and a full clean in functional risk 6 monthly. The next step in aligning your already established cleaning processes to the new standards is determining cleaning responsibilities within the setting. The standards do give recommendations on which staff groups should be responsible for cleaning which items. However, it is ultimately for each organisation to agree this locally, as is the usual process with your already established service level agreements. It's important to note that the document will not replace the local infection prevention and control and cleaning policies, but they will be part of the policies going forward. And of course, staff must be adequately trained and resourced in order to clean properly. This is an example cleaning responsibilities framework from the National Standards document. So if we look at the first line, the item is a bedpan, a reusable bedpan, bedpan holder and patient wash bowls. So it's recommended that after service user use, that the ward, department or clinical team wash the item. The daily clean responsibility would also lie with the clinical team, and the periodic cleaning responsibility would also lie with the clinical team. If we look further down in this example cleaning responsibilities framework to line 14, patient bed and trolley mattresses, it's recommended that the cleaning team clean after patient use or if visibly soiled. It's not giving a recommendation for a daily clean, but it is recommending that the cleaning team are responsible for periodic cleaning responsibility of this item. The next part of implementing the National Standards of Healthcare Cleanliness into your setting is auditing. An infection control audit schedule inclusive of cleaning should already be in place. However, the audit related to these standards is separate, and it does not replace a general infection control audit, but it is designed to focus purely on the standard of cleaning only. The infection control audit should be carried out by the lead for infection control with support from other staff, and a record of the audit must be maintained. The National Standards cleaning audits, however, should be carried out by the cleaning manager if you have one, or the infection prevention control lead, or practice manager or registered manager of the care home if not, and the decision should be made locally. The audit scores for each functional risk area are represented in 2 ways. The first way is a percentage for internal verification that a safe standard has been achieved, and the second is a star rating score, and that's for external verification that a safe standard has been achieved. This table within the National Standards of Healthcare Cleanliness document outlines what star ratings will be given to what audit percentage for each functional risk area. So if we look at functional risk area 1, for example, an achievement of 98% will be given 5-star rating. An achievement of 97 to 95% will be given a 4-star rating. An achievement of 94 to 92% will be given a 3-star rating. An achievement of 91 to 89% will be given a 2-star rating. And any score below 88% will be allocated a 1-star rating. Star ratings are widely used in industries such as hospitality. They are simple and effective means of providing meaningful information about quality. A star rating for healthcare cleanliness will be instantly recognizable and easily to understand for service users. It's recommended that star ratings are displayed in areas visible to service users and close to the Commitment to Cleanliness Charter. Organisations may deem it impractical to display star ratings in some areas. The local decision on where to place a star rating poster should be documented and added to the cleaning policy. During the first 6 months of the implementation phase, each organisation needs to only display their score as a percentage for each functional risk category, not the star rating. But after 6 months, the star rating should be displayed. The National Standards document does provide templates for star ratings 1 to 5 that you will be able to display within your setting, and this is what it will look like. Efficacy audits are observations of cleaning practices to check that training, infection prevention and control, and health and safety are applied. They should be conducted by multidisciplinary teams, including all staff responsible for cleanliness. Each service user-facing area should be audited annually. If an area falls below 80%, it should be re-audited within a reasonable time frame to check that following any remedial action, it is now achieving an audit score of over 80%. Findings should be used to develop an improvement plan, which may include further training, investment in new equipment and materials, increased supervision, increased resources, changing the times of cleaning, performance management, etc. And thankfully, a 38-point efficacy audit template is available to use within the National Standards document. This is the efficacy audit template within the National Standards of Healthcare Cleanliness document. The Commitment to Cleanliness Charter. Organisations are required to display the Charter in public-facing areas. The display locations will be decided locally. The Charter outlines commitment to achieve a consistently high standard of cleanliness. Templates are provided within the National Standards document so that charters are of the same standard and format, so easily recognised by public and staff, but some fields and headings within the Charter with pertinent information are fixed, for example, cleaning task frequency and responsibility. It is a best practice recommendation to conduct external assurance audits in order to provide an independent review of cleanliness. It is recommended to perform these audits annually. Collaborating with neighbouring providers is often the easiest approach, and this can also be led by patient-led assessments of the care environment, but it is ultimately up to each provider to decide locally if and how they are going to conduct external assurance audits. Thank you for watching the NHS Kernel presentation for guidance of implementing the National Standards of Healthcare Cleanliness for care home providers and primary care. If you have any queries, please do not hesitate to contact the Infection Prevention and Control team via their email address, which is on the screen. Thank you.